Good morning, everyone. Thank you at the outset for joining us on this panel discussion on India's way through the second wave, organized by Ashoka University as part of its Distinguished Policy Speakers series. My name is Rini Simon Khanna, and I will be your host, guiding you through this discussion over the next 2 hours or so. The Distinguished Policy Speaker series brings together individuals from diverse spheres who share their learnings and experience with students, staff, and faculty members of Ashoka University. Who better to tell us more about this than Professor Malabika Sarkar, the Vice Chancellor of Ashoka University and a former Vice Chancellor of Presidency University, Kolkata. She was the first Dean of the Faculty and Research at Ashoka and was until recently the Principal Academic Advisor before becoming the Vice Chancellor. It's over to you, Professor Sarkar.
Thank you, Rini. Good morning to everyone. And on behalf of Ashoka University, it is my great privilege to welcome all of you to this exciting panel discussion that we are all looking forward to listening to on India's way through the second wave. This is a pandemic that really defies any description. We've been looking at many earlier instances of such pandemics and pestilence, etc., in literature. But there's nothing that really compares with this. And in the 21st century, with so much of medical advancement, that the world should be brought to this state, it is really something that is very difficult to try to explain. I hope that we will get some way towards that clarity in this panel discussion today. But on behalf of Ashoka, I would like to say that yes, we are a liberal arts and sciences university, and many sectors of Ashoka has engaged with, they have engaged with various aspects of this pandemic from sociological points of view, from the points of view of psychology, mental health, etc., etc. But the most significant work, naturally, has emerged from the sciences. So we have made I think, an important contribution to discussion and debate about this pandemic. And that has come through the work of our scientists, two of whom are panelists in this panel discussion today. We have also reached out to government with many kinds of advice and guidance. We have also communicated to the rest of India through conferences, webinars, and a variety of other ways. So because this is the time when the world needs to come together to fight the pandemic, I think Ashoka has done a great deal of work in that direction. And all of us are very committed from the ground level of looking after workers, looking after students, looking after faculty, looking after our own, and then reaching out to the rest of India. And what can be done in the midst of all of this? So it is, something that's very much in our thoughts every day. As a university, as we manage to handle the campus, and as we manage to handle knowledge structures that evolve from within the university. Now, the key to handling a crisis of this kind, of course, is anticipation. So what is the level of anticipation that could have been there before the second wave? Was that anticipation level high enough? Were we prepared, at least partially, for this second wave? And now that the second wave is here, what do we do now? How do we prepare for any such eventualities in the future? So these are all vital and in many ways deeply troubling questions that we are all asking. And we are looking to experts in the field for guidance. every one of us coming from our own spheres, each one of us wants to know. We want to know more about this. We want to know more about how the world, how India, how our local community is grappling with this. What can we do that might be better? What else is there for us to do? So there are a whole host of questions that are in everyone's mind. And today's panel discussion is very important, significant, and I think for all of us, an essential event. We need to have questions answered. And who other than the distinguished panelists today who can guide us in these directions? So from Ashoka University, sincere thanks to the distinguished panelists for sparing time for this discussion. Thanks also, of course, to the organizers. And I have had many interactions as part of the Distinguished Speakers series, and I know of the great work that they have been doing for a long time. And indeed, thanks to also all of the participants. So with my sincere thanks to the distinguished panelists, to the organizers and participants, it's my privilege to once more, on behalf of Ashoka University, to welcome all of you to this panel discussion on such a critical subject. I wish you all a very good morning and a great time in the next 2 hours. Thank you.
Very much, Professor Sarkar. You have very rightly flagged some of the important worries that we are facing today. And as I mentioned earlier, our theme for this discussion, India's way through the second wave, is a topic way past its discussion stage. We would have been knee-deep in sorting the mess out. Instead, we are really clearly floundering here. Thank you to all the participants who've joined in. I have about 260 already logged in and more coming our way. So welcome to all of you. India has topped global charts of daily new cases, and several of our states, including Delhi, are reeling under a massive caseload of infections and scarcity of hospital beds, oxygen supplies, you name it, everything seems to be in short supply. Yet COVID numbers are only rising at a breakneck pace. Over 2,000 people are dying every day, and India's healthcare infrastructure is overstretched beyond belief. The second wave of COVID infections has put India in a bind, with the center and the state doubling down efforts to bring the worrying situation under control. And what's worrying is that the wave is showing no signs of waning. Daily infections in many states have far exceeded the peaks of the first wave that we have already witnessed, and the current wave of COVID-19 is not even sparing little children. Every hour, there are heart-rending reports of shortages impacting patient care, lack of hospital beds, oxygen tests, vaccinations, drugs, and medical staff. Ambulances are scarce to find and ill-equipped to cope for the long wait. Crematoria are full, and everything is in shortage, as I mentioned before, and the situation is beyond dire. Looking forward, it is essential that we understand our current situation and what got us here, anticipate what might unfold in the coming weeks, discuss lessons from what we're experiencing today for the future course of the current pandemic and the large-scale changes we need to see in the Indian healthcare in the future. So to discuss all of this, we have a diverse panel of experts, all equally well-known and established in their fields. And I would like to very quickly introduce them to you. In addition, we would hope that there would be clinicians who would join us in our discussion, people who are in the front line treating COVID-19 patients, and we hope that we can get their views also of the unfolding situation. The format that we follow for this 2-hour webinar is simple. We will hear from our team of panelists, and then I will pose a few questions to them for us to be able to start off discussing the issues in detail. Incidentally, we are on Zoom. We're also on Facebook and on YouTube. So welcome to all of you who are joining us from the various platforms. You are welcome to post your questions in the chat box, and we will try to accommodate as many as possible within our time frame. Let me begin now by inviting Dr. Gagandeep Kang, the Professor of Microbiology at the Wellcome Trust Research Laboratory, a division of Gastrointestinal Sciences at the Christian Medical College, Vellore. A vaccinologist, she was formerly the executive director of the THSTI in Faridabad. Dr. Kang is known for her interdisciplinary research studying the transmission, development, and prevention of enteric infections and their sequelae in children in India. She was the first Indian woman to be made a Fellow of the Royal Society. Dr. Kang, please outline your concerns at the start.
Thank you very much for the introduction, Rini, and thanks to everybody at Ashoka for inviting me back here. So sometimes, problems are obvious and solutions are in general known. And we are in a situation today where the problem is too big to hide. It's perhaps the scale of measurement is not feasible with any level of accuracy, but we've reached a point where it's obvious to the entire world that India has a problem, and there is no way of us being able to deny that there is a problem. Now, how did we get to this situation? Is this a problem that is, was there something we could have done to avoid this? And I was particularly struck by this because I was reading in a paper this morning that there is a solution, and this was from very respected scientists who were talking about, should there be an alternate plan to vaccinate India? The argument that they make is that if we look at the pandemic last year and we look at what is happening this year, essentially what we are seeing is a pattern that is replicating itself. There is a lot of disease in Maharashtra, there's a lot of disease in the southern states, in Delhi, and therefore, if we are to think about vaccination strategies, we should just follow last year's pattern, and that will give us a pathway to geographic distribution of immunization, which may prevent the further growth of the pandemic. And to me, that pretty much is looking under the lamppost for cases. And this has been an issue for us. There are states that have a reasonable health infrastructure, a reasonable public health system. Those are the states where we know about what is happening in terms of testing, in terms of cases. We have a sense of what is going on there, and it looks to us that disease is concentrated in these particular states and in cities, because cities have the ability to test and report. But is this really true? And I think from what we are seeing that is not necessarily the case. What we are seeing is that disease frequently starts in cities and then begins to spread. And once it gets beyond a certain level of the system to be able to measure where disease is, we lose sight of it. And when we use that approach to flawed data to think about control strategies, then we are only creating a situation where we are not going to have a logical approach to what we should be doing in the future. Now, in any pandemic, the most important thing is to be able to identify the problem and to continue to be able to monitor the size of the problem, whom it's affecting, where the cases are, what is being done about them. Because when you introduce interventions, you want to be able to measure that the interventions actually have some level of impact. So that leads us very directly to the ability to diagnose and to measure. We don't have systems to be able to do this. So if I look at the numbers that are put out by the government, we have the number of tests that have been done, the number of tests that were positive, the number of deaths, the number of active cases, and the number of recoveries. Now, that is data that really depends on who's being tested and where, and why they are being tested, but we don't know that. To some extent, we don't even know whether the tests that are being reported are the same test, or whether there is a mixture of tests that's reported. Even if we look at RT-PCRs, for example, do we know how many RT-PCRs are done by which kind of assay? And believe me, as a professor of microbiology, I know that that can make a huge difference. So if I was to look at everything that has been reported, what I see are data that does not tell me how to respond. It's only when the problem has become too big to hide that we have started to see that there is an issue and people have begun to talk about responses. Now, is this good setup for the future? Obviously not. What would make a prepared health system in terms of measurement of the size of the problem? There is a lot that we can discuss about that. So far, I've highlighted issues, I've highlighted problems. This is something that is one part of a bigger whole that we will need to work on. But I would like to give a shout out to the many, many volunteers from across many disciplines that have actually come together to create data sources that go beyond what the government has to offer us. And obviously some state governments do better than others, but at a level that data are usable by modelers like Gautam and Ramnan, there has been heavy reliance on sources of data that have come directly from state governments and data that have come from the many volunteers that have put information together from official and unofficial sources. Now, I will leave it at that and come back to answer questions.
Right, thank you very much, Dr. Kang, for highlighting a lot of the key concerns that are there today. I'd like to now move on to Professor Gautam Menon, who is the Professor of Physics and Biology at Ashoka University, Professor with the Theoretical Physics and Computational Biology groups at the Institute of Mathematical Sciences, Chennai, and Adjunct Professor at TIFR, Mumbai. Professor Menon has been awarded the Swarna Jayanti Fellowship of the DST and was elected a Fellow of the Indian National Academy of Science. The modeling of infectious disease and its implications for public policy is a long-standing interest of his, and his group provides modeling input for COVID-19 to a number of local governments and states. So it'll be interesting to hear what Professor Menon has to say.
Thank you, Rini. So I want to discuss a question that I think everyone on this panel is asked at least once a day, which is, when is this going to end? Where is the peak going to come? What do you think is going to happen? And people believe that because we work in we look at COVID numbers for a living and we think, well, that we have some special insight in this matter. So as someone who works in mathematical modeling, who thinks about models for a living, I can tell you that this is a particularly difficult question to answer. First of all, it depends upon who's doing the modeling, what models they use, what data they look at, and what their idea is, essentially. What is it that drives them to a particular answer? There are traditional epidemiological models that have been well studied for the past approximately 100 years. And this, you can put in a lot of complexity that is part of how we understand COVID today. The fact that a large fraction of people who are infected with COVID-19 will not develop symptoms, they're asymptomatic. That some of them will have symptoms, they can be mild, they can be severe, and a small fraction of people will die as a consequence of the infection. So these are all put into the sort of models that are, as I said, these traditional epidemiological models. There are statistical models that one can combine with these epidemiological models, really to estimate what the parameters are that go into this. Of 100 people who will be infected, can we expect that about one person will die as a consequence? Or is that number potentially small? Is it, if you take 200 people who are infected, is it one person who will die typically as a consequence of that infection? Then there are models that are just essentially fitting a curve. You see a rise in cases and you try and see what is the function that might fit that. What's the smoothest line that I could draw through that? And that relies on some experience with similar looking curves in the past. But it's important to remember that not every disease is different. And there is really very little that you can take from previous information that you can use here. Every pandemic is of a different sort. Finally, there are machine learning models that are complicated computational models that try to learn from the past in complicated ways to try to understand what are the patterns that may have led to a certain rise and a fall in cases, deaths, etc. Using computational tools and methods that are not very transparent, so they're not very interpretable in terms of being able to say, this is what drove it now, this is what drove it then, this is what's happening in Kerala, this is what's happening in the Punjab. So this complexity is part of all of this. To very quickly summarize what models are saying at the moment, roughly, most models now say that we would expect a peak in cases around the middle of May. And this is, this covers a sort of large range. And people like Bhramar Mukherjee and her colleagues would say maybe between the 10th and the 15th of May. The DST supermodel seems to be sort of have shifted its goalposts a little bit, but around the 14th to 15th of May is their result. IHME predicted a peak in infections about a couple of days ago and a peak in deaths a little later. But roughly, it's at least interesting that most models are converging on this broad period. And the safer models will say that there is very little that we really know about what's going on, and things are going to be complicated for reasons that I will describe. But it's interesting now that there is some convergence on this, and that was something at least that one can aim at. There's many important things to remember. First of all, deaths lag infections. So a peak in infections now means a peak in hospitalizations about a week to 10 days later, and a peak in deaths about 2 to 3 weeks later. So these peaks appear at different times. The IHME model, as I said, predicts that infections have already peaked a couple of days ago, which doesn't quite seem to be right. And in general, with models that claim very, very specific small windows of 3 days or 5 days, there are always going to be problems because there's just too much that can happen between now and then. There are many, many larger problems, and these are, I think, absolutely crucial to thinking about it. And that's what gives you this wild uncertainty in predictions. I've said May, but really it could be June, it could be a little earlier. And as it is, what I want to represent to you is that these are guesses. At this point, they're as informed as good guesses as that you can get. But finally, there is much that is unclear. And I will tell you why it's unclear. First is testing. As Gagandeep pointed out just now, if you're looking under a lamppost, you will see what's under a lamppost, and you will not see any of the stuff in the darkness that surrounds the light that comes down from the lamp. So testing now, India's test positivity rates are at about 20% across the country, and in Delhi and other places, it can exceed 30%. Why is this important? Because there's been a sudden decline in numbers between yesterday and today. The numbers came from about 354,000 cases in a day to about 319,000 cases in a day. But if you look at the test over the last 3 days, they've jumped by a factor of about 200,000. They've decreased by a factor of 200,000. So 10 or 20% of that number is precisely the amount that is required to account for this large discrepancy. So changes in testing, especially by such large amounts, can crucially affect the numbers that are coming out and the numbers that are being reported. There are large delays now. Currently in Delhi, I think it can be 3 to 5 days before you can get a test that you require, that you ask for. And there are further delays of 2 to 3 days in getting the results back from those tests. And right now, much of India is going through some sort of intervention. Delhi is under a lockdown. Karnataka state has entered a lockdown since yesterday. And the effects of these on cases will, of course, to a certain extent, inertia will carry you forward. But then at some point, the effects of the lockdown itself will begin to kick in, then you will see a decline in infections. How is this going to affect what happens India-wide? over a longer term. And the important point is really that India is such a patchwork of extremely complicated local epidemics going on, that the only sensible way to do it is to build up from the local level and try to understand what is happening at the national level. The last few points I wanted to make is stuff that models don't put in, but potentially could be very important. Most models, maybe all models, don't account for reinfections. And there's a considerable uncertainty now whether reinfections are important, whether they should be included at all, or whether they're just small in numbers. What about breakthroughs in vaccines? People already infected once, already vaccinated once. What is the likelihood that they may catch an infection? Again, there are anecdotal cases. We may know of some cases in our own. But how important is it to account for this, given that now we vaccinated around 140 million of our people so far? What happens with the new variants? How do the new variants interact with older infections? Do they lead to milder disease if you've already been infected by the older strain? If you're infected again with the newer variant, imagining that that's possible and that's important, does it usually lead to more asymptomatic disease compared to symptomatic disease? The most major issue for us, for anyone who thinks about modeling, anyone who thinks about projection, anyone who tries to imagine what's going to happen in the next 2 weeks to 3 weeks, is the question of data. Right now, data is very corrupted. It's good in some states, it's very bad in other states. And we know this from practical examples of brave journalists who go out and tally numbers between government numbers of deaths and cases and actual records of cases, people they see, people they meet, the long lines outside crematoria. This is going to be devastating to obtaining any larger picture of what's happening across the country. And so I would really make a plea here that the importance of data to any understanding of what's going on should really be paramount. So let me just stop there and hand it back to you, Rini.
Very interesting. I mean, you've raised a lot of pertinent questions and flagged a lot of concerns. And as much as this is, challenging for us, it's also exciting to know that there is this correlation between testing, between data collection and, authenticating all of this. So let's quickly move on to Professor Priscilla Rupali. She's the professor in the Department of Infectious Diseases and deputy chair of Hospital Infection Control at the Christian Medical College, Vellore. Dr. Rupali is the coordinator for the highly acclaimed annual international short course in tropical medicine being held at CMC Vellore every year, and her department pioneered promoting infectious diseases as a clinical specialty in India. As a head of CMC Vellore's guideline development team, Dr. Rupali, Professor Rupali, has been in charge of developing treatment guidelines during a pandemic when evidence is shifting rapidly, as was referred to by Professor Menon. So, Dr. Rupali, if we could have you on.
So thank you, Rini, for that introduction. And thank you to Professor Menon, Professor Jamil, and others at Ashoka University for inviting me. So I'm an infectious disease physician at CMC, and I also look after infection control, as was alluded to. And these 14 months have been extremely challenging for us. So Vellore was perhaps a bit fortunate in that each time, whether it was last year or this year, our peak has been a little later. So 2 months behind Mumbai and Delhi. So in a way, last year it did give us some time to prepare to be ready to face this pandemic. And in the months of Jan and Feb, we had actually put in place protocols to ensure staff and patient safety. Though we did know much less about the mode of transmission, the clinical presentation of patients, what were the possible complications that could ensue from the disease, what therapeutic interventions were efficacious, and most importantly, at which point in the natural history of the disease should they be implemented. We also had no information about which population was at a high risk of dying, which was the population which would go on to getting ventilated, which ventilatory strategy was better. All these were conundrums that we faced last year. And of course, to add to the confusion, we had varying guidelines by different institutions. Guidelines that were available were not often evidence-based, and really there was no attempt to involve the expertise that is actually available countrywide. There are also issues with stocks of PPE, drugs, oxygen, or even beds. Doctors were untrained. They were not confident of looking after patients with COVID. They were panicked about their safety and that of their families. So how did this help us with regard to the second wave? And second wave in numbers truly has decimated us. And we are seeing double the number of patients. Percentage, though, that's going on to severe disease seems to be about the same. But yes, the population has shifted a little bit. It's involving the younger population. We are seeing more women than we did last year. Last year, for a bit, we thought, okay, maybe pregnant women were safe from this disease, but now we know that's not true. Children seem to be protected last year, but again, this year that doesn't seem to be true. Surprisingly, there were, because of this varying demographics that were available, there were also a lot of articles which talked about, was progesterone actually a protective? And that's the reason why pregnant women were not becoming sick, unlike the influenza pandemic that we faced. We now know, of course, that that's not the case. Treatment-wise, we do have a little more data, but has that really helped? There are very few interventions that truly impact mortality or prevent admission into hospitals. But there are plenty that have been reported in literature, some of them peer-reviewed, some of them not peer-reviewed. And really the expertise needed to critically evaluate these and implement these has been lacking. And in addition, we need to contextualize each of these interventions to our Indian healthcare system, because for us, costs are important, and we need to kind of take cost benefits into consideration when we are dealing with a particular intervention. So what has happened at Vellore? When the pandemic did hit us, as I mentioned, we had about two months to prepare. We had kind of taken stock at that point in time, and we were kind of able to manage with stocks of PPE, whether it is disinfectants or oxygen, etc. When it did hit us, though, we realized that we were unprepared for a lot of things. We prided ourselves on the fact that we had prepared ICU beds, we had many NIV machines, but there were a lot of other things that we did not take into consideration, and that was staff exhaustion. So what did we put into place with regard to that? We had to innovate quite a bit, we realized, because we did an oxygen supply inventory. And then as a result of that, thankfully, we did make an oxygen generator plant. We put in some experiments to decide whether or not our N95 mask could truly be re-sterilized. As you remember, last year, there was a severe shortage of various personal protective equipment. With regard to the treatment guidelines, yes, we did have a system of sifting through evidence twice a week. We had this, luckily, we had this group of experts in-house who came to this meeting and were able to give up their time and their expertise. And we were able to roughly put some evidence-based guidelines together. When the numbers did go down, we did approach the Cochrane ID group as well, asking whether they could kind of help us create guidelines which were applicable to a low middle income country. And we hope to be able to get something out very soon. Now, Dr. Gagandeep has alluded to the vaccination. And initially, for us, the vaccination started in the month of January, and there was a lot of vaccine hesitancy. That was a huge challenge for us. But luckily, we were able to kind of go from department to department. I think in a day, we had done like 10 training sessions for the various staff. And today, I think most of our staff have been vaccinated. But has that really helped? And just today, my infection control officer told me that we have crossed double of what we did last year, the percentage positivity. So Professor Menon, today our percentage positivity was 50%. So it's been really, really challenging. And in addition, we've also had demoralized staff who have been vaccinated, who have been reinfected, they've been vaccine failures. And in turn, they're kind of terrified of passing on this infection to their families who really do not fulfill the criteria for vaccination. Dr. Menon also asked me to comment on what's happening in the rural areas. So as you know, CMC does support a network of mission hospitals all around the country. And we've had various training interventions that have been ongoing to help them with implementing non-invasive ventilation in their setting. teaching them how to interpret ventilatory strategies in their setting, how to appropriately use oxygen, what are the low-cost strategies that they could employ to actually treat their patients, whether it's steroids or whether it's inhaled corticosteroids. It doesn't matter if they did not have, remdesivir or tocilizumab, etc. The one thing that has remained a challenge, and I think that's a challenge whether it was tertiary care or secondary care or even primary care, the cost in setting up these infrastructure to deal with this pandemic has been prohibitive. So whether it's creating extra ICUs, employing more people, buying more equipment, buying drugs which were quite expensive, and then of course giving it to patients who are actually suffering from loss of revenue due to the lockdown, and giving it to these poor patients who cannot afford it. I think the other problem is that we are unclear about what the needs of these hospitals actually are. And because we are unaware of the needs, we're also unsure as to how to equip them. Just yesterday, we had multiple WhatsApp messages going around about a couple of mission hospitals who had run out of oxygen, etc. So I think this is going to be extremely challenging. The tertiary care hospitals are better equipped. We've learned from last year, but what's happening at the secondary and the primary levels, we don't quite know. We don't even know what the needs are. We don't know how they're equipped to deal with this going forward. So this is really going to be a challenge. And I really hope we're able to put in place corrective strategies to help us. So thank you. I'll stop here.
Thank you very much, Professor Rupali. You've clearly been facing a tough time, and our heart goes out to you as you've been struggling with this, as many of us have also been doing so. Dr. Ramanan Lakshmi Narayan is an economist and an epidemiologist. He's a founder and director of the Center for Disease Dynamics, Economic, and Policy in Washington, D.C., a senior research scholar at Princeton University and an affiliate professor at the University of Washington. His research on epidemiological models of infectious diseases and economic analysis of drug resistance on public health has got the attention of leaders and policymakers worldwide. So I invite Dr. Lakshmi Narayanan to add his comments.
Thanks, Rini, and thanks to the Ashoka team and Shahid for inviting me. So we are in a tough situation, but I'd like to go back to a year ago, probably January or February. And I was doing this in the context of someone who was writing a book on this, David Quammen, who wrote this book called Spillovers a few years ago, talking exactly about what we're going through. And it was cathartic for me because that was probably a very difficult time for many of us, because the starting point of this virus is really quite simple in a sense. I've taught for many years a class on disease modeling and economics and behavioral responses at Princeton. And the kinds of simple models that you do there don't really apply usually in the real world, because usually there's existing immunity. You never start from zero. But what's unusual about this novel coronavirus is that, and this is just not my thought, this is something that many people had thought about right at the beginning, which was that this is a new respiratory virus, highly infectious, but to which we had no prior known immunity. And the only previous instance that we know of this is really of SARS-1, which was in 2002, and which died out for reasons that we don't really understand. And we were fortunate because it had a higher case fatality rate. And in this case, it just happened to mutate, stick around, didn't really disappear. But really, the 1918 flu pandemic is not a good comparison from that perspective, that the influenza virus keeps mutating every year, so you have changes. Sometimes it becomes far more lethal, but at the end of the day, we still have experienced flu viruses before in some way, shape, or form. And this particular virus was unusual for that, which is why it was, in one sense, easy from a projection standpoint to see that this could have devastating consequences, not just for India, but for many countries around the world. Now, when this was said more than a year back, I think the response was both a shock and horror, but also an immediate sense of denial. People questioned if these models were right, what do you really know about this? They question credentials, and people are not really interested at some level on science, except for people actually, on this panel who know better. And I remember, a message from Gagandeep at a time when I was, I'm not on Twitter, but, when there was a lot of attack on Twitter. And she said, you're doing the right thing, stay the course. And that was really meaningful at that time, because this was something which was so obvious at one level, because you can see where it is going, but it's hard to translate to other people in science, forget about to the lay people, because it is something which was easily predictable in a sense. And the message at that time that that we put out was that it is going to be terrible unless there is something unusual, and an unusual thing might be a lockdown, which was called for in early March. It came into being. Now, even I could not have predicted. The one thing that's easier to predict is the virus. The thing that's difficult to predict is what policymakers will do. In fact, it's virtually impossible. I have to admit that even as of March 15th, when talking to people at Niti Aayog, when they were saying, "Oh, but we're not sure if this is going to be a serious issue for India," I could not have predicted that March 15th, by 9 days later, India would go into lockdown. I don't think they could have predicted that. But I think that the warnings were significant enough, and I think that there's a lot of credit, I think, to the folks in this group and outside, who sounded that alarm strongly enough that the country did go into lockdown with just 500 cases. And I think this is the most, despite the many secondary impacts on migrants and so forth, all of which should have been prepared for, this is what really saved us from a massive wave that would have hit us last year but for the lockdown. Now, we know on hindsight, based on data, that the reproductive number nationwide is about 2 to 3, similar for states that we have very detailed data on, like Tamil Nadu, Andhra Pradesh, and Uttar Pradesh. And the lockdown really knocked it down significantly. But the other aspect of the lockdown was that it also changed people's behavior, because it brought a sense of seriousness about the problem, because people could see that cases were rising even with a lockdown, right? So you start with the basic assumption, new virus, warning, there is a lockdown. But the plot was lost when people failed to realize that the lockdown was to delay the problem. It was not to deny the problem. The problem would come back at some point, but it was only going to be a temporary issue. And even the mortality last year, I think, as Dr. Kang and Dr. Menon spoke about, was actually much higher than has been reported. Simply because, you do the math. India has 8 million deaths a year. And again, all this is stuff, again, that was said back in February, nothing new that I'm saying differently now. India has 8 million deaths a year. And an additional million deaths. I know everyone gets shocked by a million deaths and say, oh, people are saying millions of people will die. Actually, a million deaths in India is a very, very small proportion. Obviously, it translates to someone in our families and it becomes a tragedy. But at the population level, a million deaths translates to just about 5 additional deaths per district. That's it. And a district is 3 million people. Now, a district may have 20 crematoria. Are you really going to be able to pick up 5 additional deaths per district? But without that, you still have a million additional deaths. Double that number, 10 additional deaths per district, which is 2 million people dying additional per year. We don't have the systems to pick that up. I mean, we don't have the measurement systems to pick that up. I mean, we have measurement systems of lots of things. I can tell you how long it'll take to get from here across town thanks to Google Maps, but I can't tell you how many people died today, right? So we lack those kinds of surveillance systems. And it's not just us, most developing countries don't have this. And also, when the deaths are recorded, only 1 in 5 deaths is actually medically certified. So we don't know the cause of death either. So the true mortality, even last year, which I really believe was probably about 5 or 6x of what has been reported, will never come into the picture until, there's some mortality estimate that is done much later, and I'm not necessarily hopeful of it because there is no incentive in the system to go out and do that verification. In fact, there are strong disincentives to do so. Now, the thing about infections as well, and some of this is a science communication problem, right? So I still get people saying, oh, but you said there'll be X million cases, but we've only had 1.2% of India infected. But at the same time, people are happy to say we've reached herd immunity. Somehow, there is no problem with simultaneously holding these completely contradictory facts in the same sentence, which is we've reached herd immunity, but only 1.2% is infected. again, it's a problem where I, I don't know how else to put it. We don't have a scientifically literate media itself. We don't have a scientifically literate, intelligentsia, because many of them repeat this stuff, and then let alone, the person on the street. And that is something which I think it takes a long time, but it's not just India, to be honest. It's many countries. The US has the same problem. So it just speaks to the fact that these are difficult, and people are not generally good with numbers and risk, and sometimes it just doesn't play out very well until they're really educated to think about what this really means in the context of a country with 1.4 billion people like India. Now, one of the things I teach in my class, in fact, the one thing I tell my students is, if you remember nothing from my class, 20 years from now, the only thing you have to remember is that human behavior is one of the most important determinants of how infectious diseases evolve. Absolutely. The viral dynamics or bacterial dynamics are important, but the behavioral response is, in some senses, far greater. And data hiding ends up creating more cases. In fact, a paper that I teach is a very good paper from HIV, Stoneburner and Lobier. So if you want to look that up, it's Stoneburner and Lobier from Science in 2004. It was an ecological analysis, but a very nice analysis showing that in Uganda, where President Museveni was willing to talk about HIV, he put in places ABC, abstain, be faithful, and condomize, the words that he made up. But he made HIV something it was okay to talk about, that Uganda was able to control HIV much better than countries like Malawi and South Africa, where it was just hidden. Now, I remember being in Botswana. I used to spend a lot of time there. In fact, one of my kids was born there. At that time, every weekend, people would say, "Oh, I have to go for a funeral. Why did they die? Oh, they died of pneumonia. They died of this, none of that." We knew they were dying of HIV. The funeral homes were doing rocking business back then, but hiding the deaths about HIV ended up killing far more people with HIV, because one, it didn't provoke a response either from policymakers or from people. Because if people knew that HIV was killing them and wearing a condom would save them, they would have done it. But you cannot simultaneously message that this is not a serious virus, it is like the flu. Indians are highly immune because we face lots of other viruses in the past. Something unusual is going on. We've had BCG vaccination. The heat will kill the virus. And each one of these has been propagated not just by the government and the media, but it's also been in every WhatsApp group that you can really think of. And this has done serious damage, because by not giving people information, accurate information, we've not allowed them to self-protect. And the act of self-protection is far more important than any lockdown. Now, we have another study. So we did one study, which some of you may be familiar with, which is a very large COVID contact tracing study. And in fact, Dr. Kang had done a commentary on it in Science as well. We have two more studies that are coming out. One is on mortality. Now, what we find in this study, which is about to come out, is that Indians are not exceptional at all. In fact, a lot of our mortality is in that 40 to 70 age group, where our mortality rates are higher than for other countries. And in fact, the biggest determinant of mortality risk, which we're able to do for this study, because this was data that's not available in many other places, is to show that comorbidities are a significant driver of mortality. I think clinicians know that intuitively, but I was just shocked. We never had data on people with comorbidities who then got tested and then went on to see how many died versus not died. And India, in that 40 to 70 age group, any clinician can tell you, is filled with diabetes, hypertension, obesity, respiratory disease. All of these risks exist, and at levels that are higher than many high-income countries for us. So, in fact, we should have been protecting these people from day one, and we just failed to do so. Now, I think where I'd like to end this thought is to say that it's important at the end of the day for us to really have, if it's good to have scientific discussions for sure, but I think that dismissing science itself is really what has happened during this pandemic. And again, not just in India, but in many parts of the world. It happened in the US with Trump. It's happened in many countries, but it certainly happened here. And throwing science out and basically saying, listen, I have a different narrative because of the misinformation, what my neighbor said. and therefore leads to this narrative of Indians not being exceptional. Risk factors don't matter, we die at lower rates and all of that. To me, this is really what has brought the second wave upon us. I think the second wave was not unavoidable, but the scale of it was definitely avoidable, and our lack of preparedness for it was definitely avoidable. Thank you.
Thank you very much, Dr. Lakshmi Narayan. Well, you've really hit on a lot of problem areas, as it were, and painted a rather gloomy picture. You've got data hiding. You've got a lot of other inaccuracies in the systems. I don't know. I'm listening to you. I'm really frightened now as to what is the way forward. But let's come back to taking up those questions and those areas of concern. I'll move on to Dr. Soumitra Pathare, a consultant psychiatrist and director of the Center for Mental Health Law and Policy at the Indian Law Society. Dr. Pathare has provided technical assistance to the Ministry of Health and Family Welfare for drafting India's Mental Health Care Act 2017, which takes a rights-based approach to mental health care. He's also served as a WHO consultant assisting low and middle income countries in drafting and implementing mental health legislation and policies. And mental health clearly is an area that we haven't paid enough attention to. Dr. Pathare.
Hi, thank you, Rini. Thank you for the invitation from Ashoka to speak here. I'm going to limit myself to mental health, largely because that's my only area of any little knowledge that I do have, and not really comment on the broader health aspects, although I might have my own personal views about it, and just kind of reflect back on some of the things that Gautam and Ramanan said broadly about health in general and about the communication aspects of it. So in terms of mental health, there is everyone's talking about how India's health system has collapsed. There has been no collapse of the mental health system. It never existed in the first place. So there is nothing to collapse. We didn't have anything, so we don't have anything. I'm not joking. This is the reality of it. I'm also not going to talk a lot of data and science in that sense, largely because I don't see my co-panelists as the audience, but really they're the big outside world there, and to try and get some messages across to them rather than to you, because getting it across to you is preaching to the converted and wasting my time. This is an opportunity to get some facts and truths out there to the average person who does not listen to some of these things. So why do I say we never had a mental health system? This is data from 2016. This is way before the pandemic. 150 million Indians. This is a national mental health survey, very well done, conducted by NIMANS. It's probably one of the best mental health epidemiological studies that would come out of India in many, many years. And they found that 150 million Indians had a diagnosable mental illness. So we're not talking about sub-threshold mental health problems. We're talking about clinically diagnosable mental health problems, okay? And 85% of them, roughly 85 to 90% of them, did not receive any treatment. So, this is the reality of mental health care in 2016 in this country. So this is nothing to do with the pandemic. If it was 85%, it's probably gone to 95 now. And that's not made a huge difference. So no collapse, only a 10% increase in people who did not get treatment. The reason it's become such a big noise is that it is those crucial 10%. Like if the treatment gap was 85% and now it's 95, the reason it's become very obvious and everyone's making a big fuss about it and saying, oh my God, no mental health care, is the 10% are people like you and me, the chattering, noise-making classes who are now getting affected by the lack of mental health care. Until it was all the other 85, the ones who are quiet, who don't talk about it, who don't have a voice, we didn't really particularly bother. So that's really one of the problems with mental health care. And, let's take suicide numbers. I mean, suicide is another thing that we've had. Everyone's talking about X number of deaths a year, million deaths a year due to COVID, or 100,000 deaths a year due to COVID. Let's take suicide. Suicides in India have, the best guess estimate for suicides in India has been roughly around 250,000 people every year. And this has been going on for the last decade, every single year. We're talking about people dying of COVID in the last 2 years. You multiply 250,000 people every year dying of suicide for the last 10 years, and that's close to 2.5 million people who died of suicide, an entirely preventable cause, for which we've done nothing. We don't have a national suicide prevention strategy. We don't have any clear ways of trying to address suicide. This is even worse for various reasons, because India's suicides are largely young. It's between the ages of 18 and 39, 40 years old. That's where our peak of suicides is, which is very different from the rest of the world. It's young people dying. So, my favorite line on this is that India's demographic dividend has been killing itself for the last decade, and nobody's done anything about it. Everyone's only talked about the demographic dividend. Well, a lot of them are already dead. There is no dividend that you're going to get out of them, because we haven't bothered to do anything to prevent these suicides. So the picture I want to give you is that this has been going on for the longest time. It isn't that it's something happened after the pandemic. And now I'm sure everyone will say, oh yeah, we know the problem, so what are your solutions? And the standard answer to solutions is always, people will say, but what can we do? We are a poor country. We don't have enough psychiatrists. We don't have enough psychologists. And that's usually the answer that I get. But where are the psychiatrists? Well, India reduced its maternal mortality by more than 50 or 60% in the last few decades, not because we suddenly produced lots of obstetricians and gynecologists. India reduced its infant mortality rate, not because we suddenly had lots of pediatricians going to every village. The fact of the matter is that if we are going to reduce our mental health gap, our mental health treatment gap, it's not going to come with psychiatrists. It's not going to come with psychologists. It's going to come if we had a proper community-based care, which can be provided at various levels by people who do not necessarily need training in psychiatry or psychology. The US has probably got more psychiatrists than the rest of the world put together. If you add up the number of psychiatrists across the world, US has more than 50% of the world's psychiatrists. USA has a treatment gap of over 30%. So clearly, having all the psychiatrists in the world for a 4% population of the world with 50% of the world's psychiatrists, if you're going to end up with a treatment gap of 30%, then really that's not the way to solve the problem. And that is something that we've really not paid attention to. So every time I talk to a policymaker, I'm left tearing my hair, because the question will always immediately be, oh, but where can we find psychiatrists? I mean, it's, you never said that when somebody said we need to do something about reproductive and child health. You didn't say, where can we find obstetricians? Where can we find pediatricians? So, why do you say, where can we find psychiatrists? So that's really been another problem, that our understanding of mental health and its solutions has always been very narrowly clinical and curative. We've really not looked at preventative interventions. There are a lot of preventive interventions for mental health, which are low cost, which are scalable, and which can be done. But we don't really look at those. In fact, if you're a poor country, actually, you should invest in preventive interventions, because you can't afford curative interventions. Your poor country can't afford to fall ill. If you're a poor country, your best chance of doing something is to prevent things from happening, not from saying we'll try and solve this problem when it happens. But that's just not happened. And people say, what is the government doing about it? Well, the government has a policy. We have we spent almost 4 years. There was a big group of a good group of some of the best brains in the country, I would say, professionals as well as caregivers, NGO activists, all involved, who put together, produced a national mental health policy. I mean, it's telling that after 75 years, India's first national mental health policy came out in 2014. But there you go, we did it then. What have we done with the national mental health policy since 2014? We've done absolutely nothing with it. Not a single strategy in that policy has been implemented. no funding has been allocated to it. It is seen as something that sits on the shelf. You know, you go internationally, you go, people say, you got a wonderful mental health policy, you must be doing very well. Well, the first part of the statement is very true. We have a wonderfully good mental health policy, which even the international organizations kind of, show to other countries and say, look, here is a great policy you should be looking at, kind of a thing. But we don't do anything about it. We're just happy sitting on it. 2014 was about 7 years ago, long before the pandemic. And we've really not done anything with the policy. Even after the pandemic, even after last year, the first wave, when everyone realized, oh, mental health is an issue. Ask yourself how much extra funding and how much extra resources did we put into mental health this year? Nothing. In fact, if you look at it, some of the budgets for mental health have actually been reduced. The health system and policymakers have raided mental health budgets and mental health resources on the pretext that people are dying of COVID, and so we need it. So, for example, in the first wave, there are stories from every single city. The only wards which were shut down were mental health wards. They would say, oh, we need to shut down the mental health ward because it is required to be made into a COVID ward. We didn't shut down cardiology wards. Nobody said cardiothoracic surgery wards need to be shut down. But mental health wards were shut down. Psychiatrists were assigned to COVID duties because it's a life-threatening crisis. So the picture I want to paint is a bleak one, and I don't have great hopes that things are going to change. And they won't change unless we actually start realizing that addressing mental health requires a gamut of interventions, taking both a life course approach, which means starting with young people, starting with adolescents, and also taking a more preventative and rehabilitative approach rather than a purely curative approach. So I'm going to stop here, and before I stop, I'm going to just make two comments on what Gautam said, and the other was what Ramanan said. Gautam said, look, this is the best guess that we have, and ultimately this is a guess. Now, this is always dangerous to use that language when you're speaking in a public fora, I think. As a scientist, we all understand when you say it's a guess, we know what you mean. It's not a guess as in you picked a number out of the air and just said, here is a number. It's an extremely educated guess. It's based on certain science. The average policymaker outside who is going to interpret that is to mean, so Gautam doesn't have a clue. And if Gautam doesn't have a clue, why don't I listen to my Baba who has a better clue? He has a perfect answer. Gautam is only guessing. This Baba is giving me a guaranteed answer. I'll listen to the Baba. So you need to be very careful, I suspect, with our language when we use, when we talk to policymakers and in public fora. I think as academicians and clinicians, we all know what you mean, but that's not how it gets interpreted outside, I think. And I think, Ramanan's been doing a brilliant bit of work, and I remember the kind of flack that Ramanan got for it last year and has still persisted with it. And I think the point that Ramanan made is exactly the point that many people have been making, that if you're going to get, even if you got 2 million deaths a year or 3 million deaths a year, they're not going to get picked up because of the way the size of the population is. And I know if you say that in a public sphere, then people, the headline that you will see is Ramanan says 2 million deaths a year is not an issue. Which is, again, something that is how it gets conveyed. So I think my point here is that science communication, we talk about science communication, but I think policymaker science communication is also something that we probably need to, as professionals, really do some introspection on how we do that. I'm going to stop here. Thank you so much.
Thank you very much, Dr. Pathare. I mean, it's really a sad and bleak picture that you've painted, and I don't know when we're going to be able to change this and, really draw attention to mental health in our country. Our last panelist, Professor Shahid Jamil, is a virologist and academic, currently heading the Trivedi School of Biosciences at Ashoka University. He was earlier the CEO of Wellcome Trust DBT India Alliance. Professor Jamil is known for his research in hepatitis E virus and has been awarded with the Shanti Swarup Bhatnagar Prize for Science and Technology, one of the highest Indian science awards for his contributions to medical sciences. The Trivedi Center, which he heads, focuses on advancing research in synthetic biology, infectious diseases, chronic diseases, and other emerging areas of biosciences and nurturing world-class talent. I'd like to invite Professor Jamil to give us his views.
Thank you very much, Rini. And I would like to thank Gautam for inviting me to this panel. Or might I say Gautam Baba for inviting me to this panel. The thing about speaking last is that everything useful that has to be said has been said. So let me come to a few points, and I will divide my 10 minutes in 4 parts. I will say a little bit about numbers to begin with, then spend a bit of time talking about the sequencing of the virus, the variants that are emerging, because that's where I have a bit more information than most others. I will look at the crystal ball and try to say, how will this pandemic end? And believe me, it will end. And a little bit at the end on how to avert future pandemics. Okay, so about numbers, let me, Cherry talked about it and Gautam talked about it and Ramanan also talked about it. Are we counting deaths properly? And the simple answer is no. Why do we say this? The normal death rate in India is roughly 7.3 per 1,000 people. And that translates to roughly 28,000 deaths per day. If what we are seeing in this pandemic in the reported numbers of anywhere between 2,300 to 2,800 deaths per day, that is barely 10% of the normal death rate in the country. If that be the case, then you would not have cremation grounds and burial grounds overwhelmed. So why is this happening? And I will come to you with a personal experience from last week when a cousin passed away because of COVID. And, he was tested on the 13th of April and his test results still haven't come out and he passed away on 23rd. So his death was obviously not counted as a COVID death. His death was simply counted as pneumonia. So that is where I think part of the problem is. I don't think that there is massive devious design to fudge the data, but part of the problem seems to be that. And so it's also the case with cases. Cases are not going to be figured out correctly if we are not testing properly, testing at scale. And this is something that both Cherry and Gautam really talked about. Okay, so let's get to genomic sequencing. So firstly, why do we sequence? We sequence to know what's in the population, but more importantly, we sequence to know what is going to emerge. And that's, to me, a more important piece of information. While the first one, what is there in the population, you can get estimates of by sequencing at low density. What is likely to emerge, meaning what is at low density today, can only be found if you sequence at high density. By December 2020, with about 10 million cases, India had only 5,000 plus sequences to show for. That's a sequencing rate of 0.05%. So clearly not something which will allow us to pick what is emerging. It allowed us to pick what was already circulating in the population. So in January, the government of India decided to put together a group which is called INSACOG, or Indian SARS Consortium on Genomics, which brought together the capabilities of 10 national laboratories to work in a concerted manner to sequence the virus. And the vision of INSACOG, and remember, this was January when cases were coming down. The vision of INSACOG was to sequence 5% of daily cases. No one had a clue that we would be talking about, 3.5 lakh cases per day. Otherwise, no one would have put that 5% figure. Nevertheless, big dreams and big visions are always good. So the group started functioning in mid-February. And since then, about 20,000 viral sequences have been done by this group of 10 labs. And that amounts to roughly 1% of cases from February onwards. And what have we found? We have found that the outbreak in India is fairly heterogeneous. If you look at Punjab, if you look at Haryana, if you look at Jammu and Kashmir, if you look at parts of Delhi, it is the UK variant of B117 which is dominating. If you look at Maharashtra, it started off with this Indian variant, which I prefer to call B1617, that came up in small numbers, but it has now grown to roughly 35 to 40% of the viral variants that are coming from there. And by some estimates from some districts, it's as high as about 60% of all viruses. Now, B1617, which our press lovingly calls the double mutant, and some people are also worried that that double mutant has now become a triple mutant, is completely false. This lineage actually has 15 different mutations, except that there are two key mutations in the receptor binding motif that allow the virus to become more infectious and to also possibly evade some antibody response. The third mutation that everyone is talking about is actually already present there. It's in another region of the spike protein that also allows the virus to enter cells more effectively. So again, making it more infectious. So firstly, this double mutant, triple mutant is the same thing. And please don't call it a double mutant because it's a misnomer. There are a lot of double mutants around there, floating out there. Just call it B1617. So at this point, what we find is that this mutant is present in 16 different states in India. And in most places, it is growing. Coming to West Bengal, which is the scene of action right now in more sense than one, West Bengal has pretty much all the variants of concern that are around, which means that it has the UK variant, it has the South African variant, and it also has the Brazil variant, although South African and Brazil are not growing there, thankfully. The Indian variant 617 is there. And as a virologist, I really believe that West Bengal is something to look to, because I think with the type of crowds that we see assembling there, the future of the pandemic doesn't look too happy a future in Bengal. Okay, so then the question is, how will this pandemic end and when will it end? Well, that depends on multiple things. That depends on vaccine availability, that depends on vaccine coverage and the duration of protection, and of course on our own behavior. So some modeling studies have shown that if immunity lasts less than a year, then we will likely have annual winter outbreaks. If immunity lasts about 2 years, a little over 2 years, then we will have outbreaks every other year. And we will have winter outbreaks if the transmission is seasonal. But of course, as Ramanan said, all this is based on influenza modeling. Coronavirus is not an influenza virus. And, we've really, this is a new virus, and we have not had any pre-existing immunity to it. Vaccination coverage is important. India started vaccinating when we were on a downward curve. But a lot of people didn't take vaccine because they thought the virus has gone away. They also didn't take vaccine because at that time, Europe was going through this whole episode and discussion on blood clots. And honestly, if you do the risk analysis of blood clots, it turns out that you have half the risk of dying from a blood clot after vaccine than you have of dying from a lightning strike. You have a far higher chance of dying in a car accident than by blood clot. So that doesn't stop us from driving a car. And the same people who are heavy smokers will say that I might die because of a blood clot, and that is sort of very, very foolish. So one message here is please go get vaccinated. Don't worry about which vaccine is the best. Just go get vaccinated because every vaccine will protect you from severe disease and from dying. And my final 1 minute on how to avert future pandemics. Well, Ramanan talked about spillovers. Why do these spillovers happen? These spillovers happen from wild animals to humans because humans come into close contact with wild animals. So pay attention to ecology. If you're going to be destroying forests, wild animals will come closer to human habitations. Can we know what's out there in animal populations before it gets to human populations? Certainly, and there is something already being done, which is called the Global Virome Project, which aims to sequence 500,000 new viruses or discover 500,000 new viruses from animal species. The trouble is the cost of the project. The cost of the project is a monumental $5 billion. Which in 2018 was a monumental sum. In 2019, it was a big sum. But certainly in 2020 and 2021, it is not a big sum because we are looking at losses of $25 trillion or higher in economic costs from COVID. The future of vaccinology is bright. New vaccine platforms have given us vaccines in less than a year, and this is one of the bright spots. Future pandemics, we will get vaccines far more quickly than we have had vaccines for this one. So let me just stop there.
Thank you very much, Professor Jamil. Well, you know really why we had to keep you for last, because you've really brought it all together and painted such a positive picture for us to look forward to. But there are a lot of concerns, and now that you've heard the panelists make their opening statements and flag some of those concerns, I'd like to now pose a few questions in attempt to find some answers if possible. My only request to our panelists is to be as brief as possible because there are lots of questions that I have and I'd like to accommodate as many as possible. Keep posting your questions in the chat box and we'll take and accommodate as many as possible. So I'd like to start by addressing a question which I'd like to request both Dr. Kang and Professor Menon to address very quickly and very briefly. How would you really characterize where is India now with the COVID-19 and what do you think is going to unfold in the future? Because we're really at a very difficult stage and there are lots of things that are up in the air. We don't know what to believe, what not to believe. Is it so bleak? Is it so, is it possible for us to surmount all this? Dr. Kant, would you take this on first?
This is a virus where 80% of people who are infected will do reasonably all right. There will be people who develop long COVID, who have symptoms that bother them for a while, but 80% will do all right. It's just the sheer numbers that are overwhelming some parts of the country right now, and in other places, it's getting worse. So we are going to come through tough times. I think in the places that were worst hit, like Bombay, partially because of their lockdown, there has been a slowing. The percentage positives are coming down. And I think if we maintain reasonable control, we will be able to do okay. And I hope we will ramp up vaccination. In the long term, where is this going? I think we're going to wind up with this being a reasonably seasonal virus. And I think part of the reason that we are seeing the second wave is because we haven't sufficiently understood the drivers of seasonality. I'll stop there and hand back to you.
Professor Menon.
Many of those points, except that I'd also add that the real, I mean, it's true that this will probably become seasonal, it will become endemic. That seems to be the best guess at this point. But vaccinations are really the only way to sort of keep some sort of curb on it. So I think people getting used, getting vaccinated, B, the possibly booster shots at the level of every 2 or 3 years. One will have to get used to some version of that, I think, in the future. I wanted to take one particular point from what Shahid said, which is when we think about where viruses come from in the first place and at what point do they spill over onto human beings, this idea of one health, the fact that you have to understand animal health, veterinary health, the health of the planet, the ecological health of the planet, together if you want to really understand human health in the context of spillover events like SARS-CoV-2 that causes the COVID-19 pandemic. One has to think about, conceptualize these drivers in a very different way. One has to have a much more larger picture of where we fit in and treat our environment with more responsibility. I think that's crucial going forward, that we have to re-examine the relationship we've had with our environment. Remember that 3 out of every 4 new emerging diseases is a zoonotic disease. It comes from animals to human beings, it spills over onto us. So that's why this is, I think, especially important right now, that going forward, we think about health in this larger picture. So.
Right. I'd like to now move on to Ramanan and Professor Jamil. Are there things, I mean, both of you have highlighted some of the things that should have been done, but, are there things that the government should have done over the last year that it did not do and hence did not avert or mitigate this current crisis? I mean, I'm sure there must have been some things that should have been done mandatorily. So Ramanan and Professor Jamil.
Shahid, why don't you go first?
Well, I was hoping you would go first.
No, you can always get the last word.
Virus is creeping closer in the meantime.
Yeah, so let me focus on one thing, and then I'll let Ramanan talk about the rest. And that is poor communication. There was a lot of mixed messaging coming through, which made people very complacent. We kept hearing that the infection rate in India is very low. It is so and so per million population. We were told that India's death rate is very low. It is so and so per million population. But India's test rate is very high, and we were always given an absolute number and not given a number per million population. So that led to some really mixed messaging and people thinking, and which is something that Ramanan also talked about, that somehow we are special. We are not special. All this nonsense about BCG protecting, or since we have a lot of malaria here and we take a lot of hydroxychloroquine, therefore we are protected. All this really mixed messaging caused a lot of problem. What happens then is, if the private cost of illness goes down, then you don't protect yourself. If the challenge is between wearing a mask and distancing and getting your next meal, it's no rocket science to know what the person is going to do. So what also didn't happen is that while lockdowns work very well in terms of curbing disease, lockdowns are terrible in destroying livelihoods. And we really didn't take care of that. So I think it's many of those things. But top of my list would really be poor communication. And if there is any lesson that we have learned, we should really learn to communicate properly, transparently, and you can only communicate transparently if you are speaking the truth. And if you communicate transparently and if people know that you're speaking the truth, then people will trust you. Pandemics are controlled by trust. Pandemics are not controlled through police action.
Interesting choice of words: communication, truth, and trust. Ramanan, would you like to add to that list?
No, I think that let me give some credit also to the government and what it did. I think that early lockdown was very gutsy. I shudder to think what would have happened if they waited even 3 weeks beyond when they actually did that initial lockdown. As terrible as it probably was the one thing that saved us at a time when the system was simply unprepared. No PPEs, no masks, no additional beds. People don't know what the clinical protocol was. And so I thought that last year, particularly in the early phase, India showed tremendous leadership. And it was at a time when, remember, other countries were not showing leadership. So India showed leadership with a weak health system, and the US, for instance, had poor leadership with a strong health system. And I think India did well in that respect. I think the problems, of course, the seeds were sown then itself in terms of the testing and things like that. The lessons from HIV, which are very illustrative for us, and how South Africa handled HIV, ended up with a huge mess on its hands. Millions of people dying unnecessarily. Was basically, those lessons should have always been there, which is, you obfuscate, you try to hide, you actually end up with a lot more people dying. And it's impossible to spin your way out of a pandemic. And it really goes back to the same communications issue, because the message then determines how the system responds. If you message lack of seriousness, why would the local hospital superintendent stock up on the necessary drugs? Why would they have done the purchase of the oxygen cylinders? Nobody in the system will do anything unless they are communicated, unless they get the message. So this is not just about individual behavior, it's up and down the chain. And at some point, when you start messaging incorrectly, then you start believing that message yourself, that you think it's actually gone. And I think this sort of self-deception went at all levels, and I'll say the media as well. The media was, is very complicit in not paying attention to science, but trying to pick up on this, very triumphalist saying India has destroyed COVID kind of a message, and it is just not helpful. I mean, I think the big tragedy was that India had the science to deal with this. Many pieces were in place for India to have done much better than the rest of the world, honestly. And I'm just disappointed that we lost that ability to translate what we had into an outcome that could have been so much better than what we have right now.
Right. Thank you so much. You've referred to the management of the treatment as such, and I'd like to just turn towards that. Did this new wave require any particular or special clinical management? And are the ages of the patients that we're seeing today coming in for treatment being younger, and even infants being infected with this? Are they sicker? And what really works and what really doesn't work? Is there a protocol? Is there a treatment management guideline that is out there? Because there's such converging and such contrasting views on this. I'd like Dr. Priscilla Rupali to please come in on this, because you've clearly had a treatment guideline in place in Vellore.
So thank you, Rini. That's a difficult question to answer. I think treatment guidelines, there are treatment guidelines now available. If you look on the Ministry of Health website, I think there was one just a couple of days it's been up. But the problem with that is, I think it has just co-opted what another premier institution has put up as its guideline. And there has been no attempt to involve expertise that has been available in the rest of the country. We have not attempted to look into the evidence that is available. So that has actually, I think, been a problem. With regard to the severity of the disease that is seen in the other age groups, or rather children or women. Is the disease any different now? No, not really. The severity of the disease, probably the proportions are the same. This is the numbers are bigger. So because we've seen bigger numbers, obviously there are more patients who are ill. We've also learned a lot of lessons from last year, in the sense the home isolation program should have actually been strengthened, which was not. And that has also led to a fair bit of confusion. So if you remember last year, a lot of the states had mandated that many of the milder patients should also have been, should be admitted. Whereas this year, there has been no information, or rather any kind of guidance with regard to what we should do about patients who have mild infections, and what to do when they become sick. Are there certain triggers that we should look at which should prompt them to come into the hospital? So that is, I think, what has led to kind of a breakdown of the system.
Also, Dr. Rupali, if I could intervene here, I mean, shed some light on this confusion. At least in the medical fraternity and among the laypersons, there is this huge confusion regarding, do we need oxygen? Do we need remdesivir? Is hospitalization critical? I mean, there's so much of ambiguity here.
So I think it's important to take each therapeutic intervention and look at it critically. So I know everybody thinks remdesivir is going to magically change everything, but no, remdesivir works on a specific subset of patients. So it's the patients who are in that magic period before they become terribly sick or they require ventilation. So it's important to be able to target remdesivir to that particular group of patients. And there is enough evidence emerging that if the patient is critically ill, there is no point actually giving them remdesivir. So which of the therapeutic interventions has really impacted mortality? It's actually only steroids. Only steroids has impacted mortality. Remdesivir, tocilizumab, and I know there's a big shortage in the country for tocilizumab. But if you actually look at the data, and we've been doing that for the last 2 weeks, as a matter of fact, madly trying to garner data, because we were trying to get our guideline out, which we've just brought out this morning. And really, if you look critically at the data there was a Cochrane, what we call as a Cochrane COVID network meta-analysis. And if we critically look at it, the relative risk was about 0.89. So really what it means is that tocilizumab, in addition to steroids, just has an additive effect of about 11%, which is not really a magic number. And that can vary anywhere from 2% to 19%. Now, when do you say that a therapeutic intervention should be employed widely and it will save lives? Is it 20%? Is it 25%? Nobody knows that. But if you closely look at the evidence-based groups, they kind of have a rough estimate of about 25% being a number, or that should be targeted for a therapeutic intervention to be widely deployed in hospitals around the country. So if we take that intervention, really it's only steroids, and it's only inhaled corticosteroids which can prevent admission into the hospital. So those are the things I think can be widely rolled out. That can be employed in any tertiary care, any secondary care hospital. You don't really need to spend like 65,000 rupees for one dose of tocilizumab, and patients thinking, okay, I'm not getting what I deserve. I need that. And if I don't, sell my house, I'm going to, and buy the tocilizumab, I'm going to die. So I think that's an important point. Okay, so does that kind of answer the question, or?
Yeah. Okay. I know there's still a lot of confusion in that arena, because there are lots of different ways of practicing health in this country. So yes, the opinions differ there. I want to just move a little now towards mental health and the bleak picture that we have there.
So Rini, if I can just interrupt and point out that what Priscilla is saying really is important. There is a lot of opinion-based guidance that has come that is still being presented in the official National Task Force guidance that is not based on evidence. We do everyone a disservice if we continue to follow those.
I'm so glad that you've spelt it out, Dr. Kang, because this is what is really, really frustrating for people who are dealing with the disease and actually on the ground level having to give out that treatment. And there's so much confusion there. So yes, we need a lot of clarity there.
I mean, can I go back to this? I think it's very important what Professor Kang is saying and what Priscilla said. And the hot favorite of all our celebrities currently is convalescent plasma. And that is something that you should also weigh in on, because it's been a bugbear for me for the last few days. Anyone who follows me on social media would know. But I think it's very important to just once and for all bury that thing and stop the nonsense of all social media influencers and people around the country running around for plasma.
Yes, indeed. Please do that.
So is the medical fraternity not speaking up enough?
I'm just asking Priscilla to comment on it, because when I write anything, people say, oh, but you're a psychiatrist. So, well, here's my chance to get the expert to weigh in on it and then be able to quote it. That's probably the most important thing.
Can I just say we are not asked enough?
I don't know whether you should wait to be asked. Maybe you should just jump in there and push this.
So we are attempting to do that, actually. So we have got a group of around 60 to 70 physicians together from all over the country who are actually dealing on the ground level with these cases. We've got them together into this group, and we've actually got Cochrane collaboration to help us. We are evaluating each intervention, and we are putting it out there for people to look at. So this has been something that has been proposed by the Cochrane collaboration, and we are hoping to do it. And this will be representative of what the physicians on the ground level feel. And actually, that's the way it should be done. And we are hopeful that we'll be able to do quickly enough.
Professor Jamil, you wanted to add something?
Yes, I just wanted to weigh in on what Soumitra just said about plasma therapy. A lot of plasma therapy has been done in India based on improper evaluation of plasma without even testing for whether the plasma has good titers of neutralizing antibodies. Plasma has been given. And this actually may have been something that has driven the emergence of mutations. You can think of it like antibiotic resistance. If the level of antibiotics in your blood goes down, then you actually select for resistant bugs. And the same thing would happen here if the antibodies are weak. Instead of neutralizing the virus, they will actually select for variants that will escape antibodies. So we are actually doing disservice by using plasma blindly. Plasma therapy has its value, but only after properly testing the plasma, which I believe has not been done enough.
I'm a little overwhelmed by all this, because it looks like a gross mismanagement of the entire treatment plan. I mean, we don't seem to be knowing what we're doing. We're just treating people with all sorts of drugs and combinations and hoping that we're going to be able to control this. I mean, it's scary. And if this is what the medical fraternity is waiting for this pandemic to unfold and take over our lives in ways that we just don't understand, I don't know. This is looking really scary. Is this what we're hoping, that we will be able to find solutions, or are we just heading out in the dark?
Yeah, really, let me actually say this, because I'm not part of this medical fraternity, and I don't believe there is such a thing as a medical fraternity. Maybe they can't say that because they'll get slammed for it, but someone who's not and that can say it. There is no such thing as a medical fraternity. There's a bunch of people doing whatever they want. I've seen prescriptions for people who have been diagnosed with mild COVID, literally 12 drugs. I had a friend who just sent me a list of 12 drugs. It's not just one person. Many doctors in established hospitals sending 12, 15 drugs, all sorts of investigations that are completely not needed, whole range of stuff which makes no sense. Fabiflu, remdesivir. Remdesivir should never be taken at home without, clinician oversight. So it doesn't require a huge amount of medical guidance. Second is the reliance on this medical fraternity, right? most people don't realize, and I think Samitra put it really well, the reduction in infant mortality in this country did not happen because of doctors. It happened because of people in public health. And when people say, well, what do you know about this? You're not a doctor. You know what? Actually, doctors are not the ones who actually save lives in the millions. They save one life at a time. But actually, there's no real understanding of the fact that public health has really very little to do with doctors. It depends on medical science for sure, and medical science requires communication. In the absence of having communicated very clearly what a standard patient who is diagnosed with COVID has put out, in some sort of national guidelines that is consistent with evidence, you create confusion all over the place. This hydrochloroquine is a big mess. I mean, India should not have been using it itself, let alone exporting it to other countries. And it was just sensitive to say this, but you know what? We're not interested in politics. We're just interested in what is scientifically valid and what is not valid. The Delhi government is pushing convalescent therapy as part of their guidelines itself, even though ICMR itself has published a study showing that it has no effect. It's an ICMR study. I mean, okay, fine, don't trust what people outside do, but at least trust what government institutions have published. I think it was a BMJ paper or a Lancet paper. It was a very good paper that showed had no effect at all, which is why what I'm upset by is that it is not that there are not extremely competent people in this country, and some of them are in this panel itself, but somehow we missed the plot and we just couldn't translate that capability into a consistent message that could have been used entirely across the country. And if you don't communicate a clear message that is evidence-based, guess what? That space gets filled with a lot of nonsense, and that's what has ended up happening.
Yeah, rightly said. We're really running short on time. I've got a lot of questions that have come in. I'd like to just take up a few of them. This is a question by Amrita Shekhar, and she asks, given there are reinfections and infections in vaccinated people, are we setting up studies to understand how the disease progresses in them? Is the assumption that vaccination prevents severe disease and death still broadly true? And I'd like to bring Dr. Kang in here. Shouldn't we be stepping up vaccinations to prevent infection and deaths? And why are we still keeping it at an optional level? Why is it not being compulsory and mandated across the board?
There are and always have been a lot of ethical issues about mandating vaccination. There are certain occupations that require a certain level of vaccination. Some schools have made vaccination mandatory, but they always continue to be a lot of discussion around whether mandatory vaccination for one particular disease then affects vaccination for other diseases as well. So there's plenty to think about. But there is no question about pushing vaccination and ensuring the highest possible coverage with the vaccines that we have at the moment. So far, we have very little evidence that vaccination is not protecting. Everywhere where vaccines have been used, real-world data are showing us that vaccines are working. There is some variability in some places with some variants, but the data on that tends to be much smaller than the data we are getting from national level rollouts of vaccination that we are getting now from the US, the UK, and Israel. What we need to be doing in India is really pushing ahead with vaccination. There are obviously lots of issues with what the government has just proposed about opening up vaccination and the pricing of vaccines, which creates such a situation that, quite frankly, my head is spinning and I have no idea how this is going to work in a situation where we have not covered the most vulnerable groups, the most exposed groups. The UK is going to start vaccination for 18-year-olds from June. The US is opening up its vaccination to adults pretty much at the same time as India. They've done much better with coverage than we have. And I don't understand how we came to where we are talking about adding complication on top of what was already complicated for a country that had never done adult immunization before. So yes, we need to vaccinate. Yes, we need to monitor. We need to get real world evidence of how vaccines are working in different kinds of people in our population. But how we are going to be able to do either the rollout or the research that needs to be done to measure impact in the situation we're in, I really do not currently have an answer.
I'd like to bring in Professor Menon and Professor Jamil into this. There is some vaccine hesitancy around people with respect to the vaccines that we have, whether it be Covishield or Covaxin. And now you've got also the availability of Sputnik happening very soon. In a situation like this, you've got transmission from person to person. Can it be curtailed through vaccination alone? Is the virus less virulent now than it was earlier? Would you kind of shed light on this?
Go ahead, Gautam.
I think Gagandeep, correct me, but there is some evidence for the fact that transmission is reduced by vaccination. It's an important point to establish. I think the issue right now is supply. It's not really hesitancy. There are more takers for the vaccines now who are waiting in queue, who are registering on the platform, but there are no vaccines available at this point. It looks as though the situation will last for at least another 6 weeks to maybe 2 months, as far as we can see. Because if you just look at the amount of vaccines available, it's probably less than, my guess is for Indian use, there will be 70 to 80 million doses per month, roughly speaking. And right now there is certainly demand for that, even in the section that Gagandeep was referring to in the over 45 comorbidities, etc. section. And so I think the most immediate problem for us now is supply. And I hope these international agreements will help us move at least part of the way through that, as well as investments in both SI and BB, as well as the other vaccine manufacturers in the country.
So I do agree that there was some vaccine hesitancy. Unfortunately, it was at a time when we should have vaccinated ourselves because we were on a downward curve. Now there really isn't any vaccine hesitancy. And as Gautam said, it's more of a supply problem. There is also this, people are thinking too much these days. Should I get a vaccine which has a 70% efficacy or 90% efficacy without understanding what efficacy really means? And 90% efficacy doesn't mean that if 100 people take the vaccine, 90 will be protected and 10 will not be protected. It simply means that for every one of us, it will reduce the risk by 90%. And there is a difference between those two things. So if a vaccine is available to you that has 70% efficacy, it will reduce the risk by 70% for you. So my guidance there is, people often ask, which vaccine should I take? And I say, take the vaccine which is most easily available to you. A cousin sent me a message a few days back asking, when will Pfizer vaccine be available in India? And I told him, are you waiting for that? If you are, then you're really stupid. And I used that same word. So today he sent me a message saying, I got my first shot of Covaxin. So that's very good. But I think it's important to understand that whatever vaccine is available to you, vaccine, if it will not prevent infection, it will at least reduce the viral load. And if it reduces viral load, it will reduce transmission. So that's very, very important.
Okay, one thing that could have helped us face the second wave, do you think could it have been sequencing of enough viral genomes to track the mutating variants? The vaccinations that we are asking, is it effective against these variants that we're seeing? Are we doing enough sequencing, Professor Jamil?
Well, I think now we are at a point where doing reasonably well. I mean, one can always do more, but as I said in my initial comments earlier, we were not. So we are doing enough sequencing to find out what's already circulating. But I think we need to step up our sequencing to find out what is emerging. And even at this level of sequencing, we are already finding some mutations of concern that are emerging. Well, this is not the forum to discuss those details. But whether it is this variant or that variant, at the end, every variant can be protected with a mask. So I get really angry when people are asking all these questions about variants and they are not in compliance with masks. They are in complete denial here. The two main variants that are circulating in the country, the UK variant, there is already evidence that several vaccines protect, including those that are being used in India, protect against the UK variant. Some early studies have also shown results that serum from people who have taken Covishield protect in laboratory experiments from B617, the Indian variant. We need larger studies to be more confident of that. And of course, we need similar studies with Covaxin, and all that will come. But in the meantime, please don't worry about this vaccine or that vaccine. Please don't worry about this variant or that variant. Just do what you're supposed to do. Protect yourself.
Picking on your point about masks, Professor Jamil, there's a question by Bhavesh Nikra, who says, Niti Aayog released an advisory yesterday. The time has come to recommend wearing a mask even if you're at home. What are your thoughts?
I think Gagandeep will answer that question very well.
Actually, that's to Priscilla. But basically, if you have someone infected at home, then absolutely wear masks at home. And if you have unknown people around you or people who have been in contact with unknown people around, then it makes sense to wear a mask. Also important to emphasize that CDC guidance says that if everybody at home has been vaccinated, then there is no need for masks. So if you need an incentive to get vaccinated, get everybody vaccinated, that's it.
What a wonderful way to put it, and easy incentive for them to get themselves not wearing a mask. I'd like to now move towards the mental health aspect and bring in Dr. Pathare. The scenes that we are seeing daily on television and other media platforms are truly horrifying. And how does one support an already burdened society and communicate with empathy in a time of collective trauma? I think you're on mute.
Yeah, this is going to be our next catastrophe, which is going to be on the horizon. Imagine being a relative or a family member and seeing your close one gasp to death in front of you, or being a clinician and having to see this on a daily basis is probably going to be the most damaging thing, and the kind of problems that it's going to create for clinicians as well as for families. The other thing that is making it worse is we normally, every culture has its own way of dealing with grief and handling grief. And while many of us have our own issues about rituals around death and all, these rituals play an important role in coming to terms and dealing with the grief and having some closure on it. What we've also now landed up doing with the way our COVID crisis has been is that we are even not allowing that. I mean, I had a 96-year-old aunt who died recently of COVID. And the two things that have upset everyone in the family, or at least the cousins who were looking after her, was very simple. They said, look, we didn't have a choice. We had to take her to the hospital because she was gasping. They put her in intensive care. I mean, it's fine. She's 96. She died, but she died alone, and we were not allowed to see her. And then once she was dead, the body had to go through the usual COVID precautions, and so they never got to actually even do the rituals that would be required for them to get closure. And because we now have a lockdown in place, it has meant that normally what they might have done on the 8th day or 10th day ceremonies or something to get some closure are not happening anymore. So all of this is really a genuine issue, and this unresolved grief is going to manifest itself in the coming months and years in all sorts of problems, not only at the individual level. I actually fear also at a society level and at the level of the community. If you've got an entire community which is living with this unresolved grief, and we know from past experience across societies where you have these unresolved grief issues, what it does to societies over time. And so I would, I shudder to think what will happen. We are not really addressing it because currently the attitude seems to be, well, people are dying and we need to take care of that rather than addressing it. There are some organizations which are offering, in care for people, allowing people to go through that grieving. But it's not something that the government or our health system is looking at doing. I mean, I repeatedly get tagged on messages, some of which are terrible, that oh, can we find a grief counselor? There are two young girls whose both parents have died of COVID last week. Can you help? Now this is the kind of messages that you see, and for every one such message that I would see on social media, I'm sure there are thousands of such people out there for whom no messages are going out. I'm not trying to be intentionally catastrophic or to make it paint a bleaker picture than it is. I'm actually trying to uh, be careful and give you a slightly optimistic picture. I think the reality is worse. But the fact is that we need to actually start acting on it. And what you need are large scale programs at the community level. There are many interesting community based programs which are there. There are many NGOs which are working in that sector which can do this. But it needs to be taken seriously. So I'm just hoping that something will happen in the next 3 or 4 months for governments to also start, because at the end of the day, the fact is that uh, private healthcare or private mental health care or the charity sector, which is the NGO sector, can only address a small proportion of the population. If we are going to have to address the mental health needs of the population, then there is a need for the public health sector to step in and to do something about it.
Right. There are a lot of other aspects of this, pandemic that we need to address, and we're really running short on time. But I'd like to take this opportunity to flag that as well. I mean, in every big city, there are a huge number of workers from other states that are poor and are without medical support. With the lockdowns increasing as we see, and no earnings coming, they are also attempting to get back home to their states. Is there any concern about this? Have we learned our lessons from the last massive exodus and the disastrous exodus that we witnessed? Professor Jamil, and maybe Ramanan can come in with his comments.
Ramanan, you go ahead this time.
I don't even know what to say. I think the audience knows more about this than anything that I could really say about it, which is that the last time it was a lockdown that was unannounced, but this time it's what I would call a reactive lockdown. I think the rate at which it's going, it will eventually have to be in many parts of the country. And I think the fair thing to do at this point is to warn people that it is coming. And it's unfair to just sort of do it again at very, very short notice. Delhi did it very short notice. But we know where this virus is going to come back. The trajectory is already in place. And I think the fair thing to do is to warn people right now. And I hope we can do that.
Yeah, I agree entirely. I mean, lockdowns, or I wouldn't use the word lockdown. I would, based on the experience of last year, I would simply say containment. And that's again a communication issue, because lockdown has a very negative psyche from last year. Uh, but it's inevitable. I think if the transmission has to be broken, it's inevitable. But hopefully, based on experience of last year, there would be better preparation to support people this time around.
Okay, so there are more than 100 questions that are out there, and I'm just not going to be able to accommodate anybody. We're coming towards the final moments, as it were. I'd like to bring in the entire panel to give us, what is it that lies ahead? You've got massive shortages in medicine, you've got shortages in testing, shortages in tracking and treating, in vaccines. Notwithstanding all of this, we've got to do something about it. So what do you think is your list of priorities? If we could just go turn by turn with everybody. We'd start with Dr. Rupali.
Oh, did you ask me first? Okay.
If you'd like to go first, yes.
Okay. I think what I would really like to see is sound science and evidence-based messaging, very clear evidence-based guidelines for how to manage various types of COVID, a very simple public health messaging around the importance of, say, wearing masks, taking vaccines. I would like to see transparency, especially data transparency, whether that is to do with the number of infections, the number of tests we are doing, the number of deaths we have, or the results of vaccine trials that we've done. Those are the kind of things that I would really like to see, and that would probably help us manage this pandemic far better.
Dr. Rupali.
So can I just say ditto? I agree with everything Dr. Patare has mentioned. And maybe add another thing. I think the aspects of not just communication and truth and transparency. Apart from that, I think identification of the various aspects of these problems and, educating people how to deal with this. So training is a very important aspect. Teaching people how to interpret data and, make them aware of how to actually interpret the science behind many of the therapeutic interventions. I think that's a very important thing, especially for medical professionals, which I think is a source of great anxiety, not just for medical professionals, but also for patients as well.
Professor Menon, if I could bring you in to just shed a little light on the economic aspect of all of this.
The economics, I think Ramanan would be a better person to answer.
I'll bring him in later, but I thought I'd bring you in first.
I can talk about, again, echoing both Soumitra and Priscilla, that I think data is very important. The ICMR sits on a mountain of data. It's a public institution that is sitting on information that concerns the health of the Indian public, but yet you have to rely on them to release it in dribbles that is not very clearly analyzed. If they could just simply talk to computer scientists and other data scientists in the country to figure out how to anonymize it, to protect the identities of the people involved, but release this for analysis by other people. We are very strong in a variety of mathematical, computational data, etc. This is the strength of our country as we are perceived outside. But we need data to work with, and this is data that is important for the country, and other people can comment upon it, improve it. But unless one has data to work with, one will never be able to say what one should have done, what one could do in the future. I view that as being very important. Sorry, just again, another point is that I think when we talk about models and modeling, we are now beginning to realize the importance of this and the fact there are relatively few people in the country who do it at the high level that is required to be able to move fast and to work completely at an international, at the top-notch level on this. I'd like to see various schools across the country that come up in response to this and have better people everywhere with different approaches to looking at modeling for diseases.
Ramanan, before you come in, there are lots of things that we could have planned better. We could have flagged, we could have identified. What is it in your mind that you think that this is that priority list that should be done and going forward, the only way out?
Thanks. I'm not going to get into a list, honestly, because the time for looking back will come and the historians will write that story quite well. I think at this stage, we collectively have to decide whether we want a PR narrative of how India handled the virus or the reality of how India handles the virus. It's a very, very sharp difference between those two. And if we want to go with the real approach, and again, I gave you the example of HIV, the only countries that did well on HIV were countries that were upfront about the virus and then dealt with it based on data, which is the same point that everyone has made. And I think we need to decide whether we want that or we want to have this triumphalist narrative, which seems great in the short run, but it's not going to surface in the long run. That's the first point. Second is, I think everyone would say that we just need to vaccinate at a furious rate. We need to figure out where to get the vaccines. We need to scale up the capacity 5x. I am actually optimistic that India can actually exit successfully despite where we are right now if we get that part right. So hopefully we can do that.
Dr. Khan, please come in.
Okay, so I have two things that I will add. I agree with everything everybody said, but for individual level advice, I would say plan for what happens if somebody is infected or sick in your family. Be prepared. Be prepared with what you need at home. Be prepared with the information that you need to get outside, to get people to care if they need it. There will be facilities in and around you. So make sure you know what the sources of information are. The second is clinical and epidemiological research underpins the practice of medicine and of public health. We do practically nothing. We need to make sure that for the future, we build that capacity out. Infectious disease modeling, Gautam, small part of all of this.
I agree.
Yes. Well, we've reached the close of this 2-hour discussion. There's so much more that we need to talk about. But you'll all agree that the past year, the current situation has been painful, has been frustrating, and many times hopeless. It's heartening that despite this unprecedented suffering and the dipping morale that the nation is suffering from, we've seen exemplary and extraordinary demonstrations of public service. We've seen doctors and nurses working 20-hour and 24-hour shifts, ordinary people doing extraordinary things to help others in need. But we've also equally witnessed hypernationalism, lax implementation, populist measures, and to a large degree, bureaucratic incompetence, all of which has combined to worsen this horrendous humanitarian crisis. The end to this health disaster seems nowhere near. We're all fumbling and stumbling to find a way out. Too many of us have experienced this season of death, despair, and abject dereliction of duty by the state firsthand. International epidemiologists are talking of an alarming 2 million to 3 million deaths by August this year. Is there a third or a fourth wave waiting to happen? Can we venture to think that we would be prepared for such a magnitude? The Prime Minister said recently, the biggest basis of India's success during the first wave of the pandemic was our united effort and united strategy. We will have to address this challenge in the same way. If we work as one nation, there will not be any scarcity of resources, according to him. These are costly lessons for the world to learn. It's beyond our imagination that despite the scientific progress and despite the systems of governance in 2021, people are suffering and dying because of callous abdication of responsibility of India's political and administrative leadership. The only way forward is using science, as the panel has been emphasizing, and proven data, positive messaging, measured containment strategies, and compulsory vaccination to contain this global epidemic. Unless public health precautions are in place, along with fairly rapidly and extensive measures of vaccination, we're not going to be able to control this untamed pandemic. And each of us has received innumerable messages and personally know of people losing the fight to COVID, and in some cases, more than one in one family. I don't think any of us have adequate words to take away the pain. To those of us who are still fighting this virus bodily or by being caregivers, just hang in there, please. For the rest of us, You're all in our thoughts and prayers. Thank you to the esteemed panel for sharing your invaluable insights and your views. Thank you to Ashoka University for the opportunity to explore and examine this subject more thoroughly. There are thousands of people who are out there wanting that information. So thank you to the faculty and the students for supporting this event. And I believe Akash would like to come in at this point and say a few words. Remember just this as I leave you. We still have a long way to go to bring the coronavirus pandemic under control. None of us are safe until all of us are safe. So wear your mask, wash your hands frequently, keep yourselves healthy and safe, and get vaccinated as soon as possible. Akash, it's over to you.
Thank you so much, ma'am. At this very, towards the end of this brief discussion, I would like to thank all the panelists. Rini ma'am has already thanked, but there's one person missing, and that is Ms. Rini Simon Khanna, who has steered the discussion so very well, knitted all the points together and made the transition smooth. It's been something that we, planned over a very short notice for the public benefit. And I really just feel that the pandemic gets over soon and people are interested in watching this video. And there's a lot of information out there that you'll find very helpful. Thank you very much. I would also like to take the opportunity to thank our Vice Chancellor, our Dean of Research, Dean Sahni, and all our students who have helped in making this program a successful one. Thanks all once again, and please wear your mask. The program ends now. Yeah.
Thank you.